Welcome everybody to this MDS roundtable. My name is Guillermo Garcia-Manero from the Department of Leukemia at the University of Texas MD Anderson Cancer Center. And I'm very pleased to be here today in this teleconference. At the IHA meeting in Madrid, there were actually multiple presentations about luspatercept. They address actually 4 different aspects of this disease that are actually quite important. Let's go with the first one if we follow the order that we have. So this was a poster actually that I had the privilege to present, where we were discussing or presenting data on this issue of multilineage responses on the COMMANDS trial. So for the audience, in the medalist trial, we had noticed, and this was, I think, a little bit unexpected, that some of these patients that were treated with luspatercept also had an improvement in neutrophil count and in platelet count, so HINs, HIPs. This was kind of post-hoc analysis where we're seeing these kind of counts evolving. I don't know that we understand 100%, the mechanism by which luspatercept, that we know affects the erythroid pathway, does this, but that was very clear. Actually, it was published in Blood, a follow-up to the medalist trial. So it was obvious to reanalyze this in the COMMAND study, and we see a signal that actually is along the lines of what we saw on medalist, where actually you see some other hematological responses. Now, the platelet one is a bit complex because a majority of these patients don't really have thrombocytopenia, so it's difficult to see a significant improvement in platelets if you already have a platelet count of 200,000 to 300,000. But there were actually patients that had neutrophil responses. My take is this is not a drug that you're going to give on a thrombocytopenic patient to see if the platelets improve, but it gives me a little bit of peace that if I use this drug in a patient that is already cytopenic, and I'm sure that we do that also frequently, this is not going to exacerbate the cytopenia, and it may be actually positive. But any of you have any take on this kind of other hematological responses that we have seen on the COMMANDS trial?
I think it's also interesting because, in order to be eligible for the COMMANDS trial, patients with particularly severe neutropenia or thrombocytopenia were also excluded. So I think in our real world practice, where maybe we are treating some of these patients who have an ANC of less than 500 and platelets of less than 50,000, would we perhaps see a greater magnitude of benefit or, maybe some more impressive responses even in these patients who, are more cytopenic, who really were excluded even from COMMAND. So it's, I think it'll be interesting to maybe get a little bit of real world data to color this, this multilineage response as well.
Excellent. Now, the second abstract that I think is interesting, I don't know who wants to attack it, Tom or Jamie, is this study looking at how in the COMMANDS trial, there was some impact of the luspatercept on these biomarkers that are associated with inflammation, cardiac function, etc. So this was actually, I'll read poster 763 from Dr. Hayati, also at the IHA meeting in Madrid.
Yeah, so I'm happy to spend a little bit of time, talking about this. So this study also did comment on some of the multilineage improvements, specifically within the leukocyte population. They saw that patients treated with luspatercept did have improvement in total leukocyte counts, neutrophil counts, and lymphocyte counts. Although what I think is more compelling is that luspatercept treated patients did have downregulation of inflammatory mediators. Now, perhaps most clinically relevant to us who are, checking labs and checking labs that are commercially available is that luspatercept treated patients, but not patients who are randomized to receive epoetin alpha, actually had decreased levels of NT-proBNP, which, as we know, is a marker of cardiac stress or inflammation. And so, I think that is particularly of interest and is very hypothesis generating. And perhaps, while not direct evidence, may play into my decision again when I'm making that calculus in a frontline patient about which agent I want to be using. Again, I do kind of think back to some of this data and these decreased levels of inflammatory biomarkers particularly the well-validated NT-proBNP level. So I think that, in particular, that was a very compelling report from this abstract, and certainly hypothesis generating, something that I think that we need to be exploring a little bit more. And I think, the question is this because these patients had higher hemoglobins, or does it really have something to do with perhaps the modification of the inflammasome by luspatercept itself, or perhaps the bone marrow microenvironment. So I think really interesting, would be really interested to hear everyone else on the panel's takes on this as well.
Tom?
I never know what to do with these kinds of sort of corollary studies. I mean, it's exciting and interesting. It suggests that maybe there is something meaningfully different about stimulating the late stage erythroid maturation part of the pathway as compared to stimulating the early stage maturation part of the pathway. But ultimately, I mean, what's going to drive my clinical decision making is the response rates and durations of the therapy. So I guess it's sort of a nice proof of concept that this drug is doing something different actually in the patient, and maybe that's part of what's translating into these downstream improvements that we measure in people's labs and transfusion needs. But I struggle with the application to the clinic.
The next abstract is by Dr. Komrocki. It was also in Madrid, the P749. And this was also presented, I believe, at ASH and the prior IHA in Vienna. So what this abstract by Dr. Komrocki suggests is that in the COMMANDS trial, the mutational burden seemed to affect more those, meaning in a negative way, more those patients that were treated with an ESA versus luspatercept. So Jamie, what do you think about this data?
So again, I think this is, another reason why I would be likely to choose luspatercept up front for my patients. And to your point, that the number of mutations seem to decrease the response to ESA-based therapy as part of COMMANDS. However, it had no effect really on patients treated with luspatercept. So again, I think that, luspatercept truly is an efficacious drug for all comers, whereas, the ESA-treated patients tended to have an inferior response as mutational burden increase. And so, again, I think that this is just, again, speaking more to indirect evidence that luspatercept really may be the more efficacious treatment. And I feel very confident kind of choosing it up front for my patients who are ESA naive, untreated with lower risk MDS.
I like the idea of just thinking of the pathophysiology of the disease. You have a hypercellular marrow with increased precursor, stem cells, or not really stem cells, but increased precursor cells in the bone marrow. The ESA is already driving what's already hypercellular, whereas luspatercept is allowing for maturation of those cells, potentially reducing inflammation. And I really like the fact that it's reducing the BNP, or the pre-BNP. I mean, that to me makes intuitive sense. As if I gave the patient blood transfusion, I would also expect as their CHF improves that the BNP is also going to improve. So it's certainly chicken or egg, but I mean it makes intuitive sense. And I kind of wish we had that the EPO when that we saw that in EPO agents as well. But since we see it in luspatercept, there's certainly, it stacks onto the other numerous benefits of that product.
Wonderful. And then the last one, and then we have a couple of other points before we conclude. It was by Dr. Santini from Italy. It was P785. I think this is kind of like a updated analysis of the luspatercept. And I see Jamie nodding. So what do you think about that final presentation or updated presentation?
Yeah, I think it's just, my takeaway from this presentation was just, again, confirming a lot of what we had seen in both the interim analysis of COMMANDS and the final analysis of COMMANDS that was presented, what was it, at ASCO this past year, or maybe the year before. Again, just showing, with regards to that composite primary endpoint of, a minimum transfusion-free period in association with a 1.5 gram per deciliter increase in hemoglobin, that, luspatercept is superior to weekly epoetin alpha in the intention to treat patient population. And that also numerically the length of response was greater with luspatercept. And, I think, Solly, this is a point that you've made, but I think we really can't underscore enough that the convenience of dosing, at least the way that these agents were dosed as part of the COMMANDS trial, all of this increased response rate, this, numerically longer duration of response is all with every 3-week subcutaneous dosing versus weekly epoetin alpha as it was given on the COMMANDS. So I think these are just kind of, again, some of the factors that I integrate into my decision-making process. And then, secondary factors being some of this exploratory data, looking at these improved pro-BNP levels, certainly not necessarily efficacy-based data or duration of response or convenience data, but just something else that I kind of integrate into my general decision-making. So I think, as we look at this particular abstract number 785, it is just reiterating what we have seen in both interim and, presented final analyses of the COMMANDS trial. And so not a lot of new information here, but I just think, reassurance on a number of points in terms of efficacy, safety, and duration of response that luspatercept has shown, superiority to epoetin alpha.